Hello, everybody. We are now on to kind of a new module, a new block of content. And so we are going to begin that by talking about drug design. And drug design is something that we've kind of got a little bit of exposure to because we've already looked at like Lipinski's rules of five. Now we're just going to kind of build out from there. So with all that in mind, let's go ahead and get started. So, drug design. Drug design or drug discovery process, you have a handful of goals. One, you want to find a target drug or a target protein that you're kind of aiming for. You want to observe how natural and native ligands interact with that target. So, if you see or if you already know about, and the example that we used was we looked at hemoglobin, HB, as a protein, and then O2 as its binding partner. So, if we have a good understanding about how those two things interact, then we could say, well, how does hemoglobin, how could it bind molecule X? Okay, well, we know that hemoglobin interacts with oxygen in this way. X is potentially going to interact with it this different way. We want to build and design a drug to interact to with that target. We want to observe the drug's absorption, its bioavailability, and its metabolism. These are all really important things because we've got to know, like, if you take a pill of something, well, what's going to happen to the contents of that pill? It's going to go down your throat, it's going to go into your stomach. What happens when it gets to your stomach? And then what happens whenever it goes to different cells, different tissues? Is it going to be completely metabolized by the liver or the kidneys? You got to know these things if you want to make an effective drug. And then, last but not least, kind of along those same lines, you've got to determine the optimal route of administration. Now, when we learned about biochemistry and organic chemistry, we studied the role of the target in a disease, as well as the important chemical characteristics of a drug that allow for those medicinal effects. Now, what we really kind of focused on there was our protein ligand complexes and those interactions. We also talked about the Lipinski's rule of five and what made a good drug candidate. So if you need to, jog back on those things and just kind of take a quick glance. Now, there's a kind of, I guess you could call it a phenomenon, maybe not a phenomenon, but there's this thing that you need to know about known as a signaling cascade. I always kind of think about a signaling cascade as like, and the way that I think about the way that I think about a signaling cascade is like, when you're a kid and you go to your neighbor's house or you go to your friend's house and you knock on the door. Okay, well, who answers the door? Well, first of all, you've got the door, which is basically the plasma membrane. That's the barrier that keeps you, the kid, the signal molecule, from just walking in there. So you go, you knock on the door, and then there is a receptor protein. That receptor protein, let's say that it's your friend's mom or something, or little sister or whatever. Um, they're going to open the door and they're going to say, "Oh, hi, it's good to see you again." And you're going to say, "Oh, is my friend available? Or can my friend come out and play?" And your message is, "Can my friend come out and play?" And then your friend is upstairs in their bedroom or something like that. So that signal needs to be communicated from here all the way down here. So that message that you're there needs to get inside to your friend in the house. And, similarly, there's like, or sorry, so, your friend's mom receives the message from you and they tell your friend's sibling, "Hey, run upstairs and could you tell them that you're here?" Okay, so that's the signaling cascade in or an example of like a signaling cascade. Well, cells have similar sorts of properties or similar sort of treatments where um a what's known as a signal molecule is going to bind with what's known as a receptor protein. That receptor protein that is found on the membrane. That doesn't go into the cell. Instead, what that does is it basically can sense what's outside and communicate that to the inside. And so within the cell, there are things known as relay proteins that communicate that along. Those relay proteins will ultimately go to what's known as a transcription factor, which for our purposes, we're going to know as a TF, a transcription factor, that's then going to be able to turn gene expression on. And that gene expression is going to lead to the production of a new protein. Now, this is an important kind of process that takes place. It's the way that um, your 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 fight or flight muscles or your fight or flight responses um, kind of are mediated. It's what, you triggers you to like jump up and your heart to speed up a whole lot, and then you to be able to run really fast. That is a signaling cascade where epinephrine, for instance, is produced in a high concentration. Your body can use that. So that's an example of a signaling cascade. Now, as you can see here, signaling cascades get super complicated. Now, essentially, it's the same thing, but there's just so many different players that are involved. Now, signaling is much more complicated than we saw previously. Now, upstream, the receptor protein communicates with many different proteins, whereas downstream, a protein may communicate with one or two different proteins. Now, when we look at something like this, what we have is here is our upstream is going to be something like our upstream or downstream. So upstream, the receptor, in this case right here, TNFR or IGFR or IRA/B, or this general receptor right here. The receptor can communicate with many proteins. Okay. So if we take this IRA/B, that's the insulin receptor protein. And what that insulin receptor protein is, it's going to be able to interact with this protein right here, this protein right here, or this protein right here. Now, downstream, a protein may only communicate with one or two. So if we think about this as uh, over here as our upstream, then IR, for instance, the insulin receptor protein, is really only going to interact with insulin. Now, when designing a drug, would it be better to target a protein up or downstream? Now, this is a little bit challenging, but it ultimately boils down to what are you trying to change? Now, receptor binding. So this is similar to what we've talked about with protein ligand interactions. But when it comes to receptor binding, so a receptor that binds to a protein, we have a couple of different terms that you need to be familiar with. There is an agonist, a partial agonist, a partial antagonist, and an antagonist. Okay, so here what we've got is our receptor site right here. This is our receptor site. And if you design a drug that is an agonist, what that agonist is going to do is it's going to be able to bind in the receptor site, and it's almost going to stimulate like the natural chemical, the natural ligand. Well, it's bound there, but the difference is that it's basically staying there. So here what we have in our first cell, this would be before a drug is present. So the natural chemical will bind, and then sometimes it's going to release. It's going to bind, it's going to release. Now, if you have an agonist drug, that agonist is going to bind to the receptor site, and it's going to kind of set up shop there. It's going to just hang out there kind of indefinitely. The antagonist drug, on the other hand, what that's going to do is that's going to kind of it's basically going to block the binding sites. that the natural chemical would go to. And what that means is that cellular response to that natural chemical is going to be blocked as well. So this is the the agonist is you can kind of look at that as ligand or the natural ligand, the natural chemical, always there. The antagonist is the ligand. I draw a little arrow so I can make it similar. Is never there because it can't go there. Those are kind of big variables when it comes to a receptor binding to a ligand. Now, we also have this phenomenon known as allosteric modulation. Allosteric modulation has basically two different kind of results. There's positive allosteric modulation or a positive allosteric modulator, and then there's a negative allosteric modulator. Now, a positive allosteric modulator is an example of a drug that is going to cause a protein to kind of take on a shape where it is going to increase signaling. A negative allosteric modulator is going to decrease signaling because it's going to cause the protein to basically lock up and not be able to do the receptor, I'm sorry, the receptor to not really do anything. Now, after we've actually found our target and the drug, what do we need to do? In order for a drug to be effective, it has to be able to be absorbed by the body and reach the target protein in human cells. So before I proceed there, everything that I'm talking about here with respect to, hey, this is the protein that we're going to look at, and here's the drug that we're going to use. Anything where we've um, tested how good the drug is, the efficacy, the effectiveness of it, that's all been done in a test tube. So you haven't seen how a person responds to it, how a disease state responds to any sort of drug. Because we're talking about this all like very we're talking about it outside of the cell, outside of the human body. So it's important to remember that proteins don't just float around in the body. They're carefully organized in specific locations within the cell. Thus, the drug has to be able to reach that target or else it'll have no effect on the disease. And so that brings into kind of discussion a couple of different things. One, we got to know about how that drug's absorbed. We've got to know about the bioavailability of that drug, the distribution of that drug, the metabolism, and ultimately how your body gets rid of it. And in some instances, your body's not particularly good at getting rid of drugs. In some instances, there's compounds that your body doesn't get rid of very well. It doesn't excrete them. Now, with that said, there are some drugs that you want to be effective for 2 hours, 3 hours. You don't want them to be effective for forever. So the first thing that we need to talk about is absorption, which I'm going to take a pause from proceeding and I want to walk back for a little bit. What I want you to understand so far from what we've talked about is I want you to know about what a signaling cascade is. What are the different players? What does the receptor do and what does the signal molecule do? And I think that knowing that a receptor protein communicates that there's a signal molecule out here and turns on gene expression by turning on a transcription factor or a TF that leads to a new protein, I think that's really a good thing to understand. So effectively on this slide, there's like 5 different things. One, you've got to know what a signaling molecule is. 2, you've got to know what a receptor protein is. These 2 things interact with one another. 3, you've got to know what a transcription factor is. That's the thing that turns on gene expression. And then 4 would be, kind of a result of a signaling molecule interacting with a receptor protein. And that result is that, well, gene expression gets turned on and that The next result, or the fifth thing, is that gene expression leads to the production of a new protein. Okay, so that's what I want you to take away from this. Those five things, a couple of definitions, and then a couple of results. Now, signaling cascades, there's tons of details here. What I want you to understand about this slide in particular is that, well, signaling cascades are complicated, and you've got tons of different interactions. And in addition to that, you've got these kind of like this one receptor protein saying this thing, and then another receptor protein's trying to communicate the exact opposite. You've got this what's called crosstalk between these. With respect to detail from this, I'm not expecting you to take away from this. I other than that signaling cascades are pretty complicated. Here, however, receptor binding, I want you to know what an agonist does and an antagonist, what that does. I think that the partial agonist, partial antagonist, will just know that they don't do it quite as effectively. So a partial agonist, well, it's not going to say that the ligand is always there, but you could say that the ligand is there, or sorry, it would be stimulating the cell in a way that, well, the ligand's there more. So that's kind of what I want you to take away from that. And similarly with the partial antagonist. Now, allosteric modulation, I want you to think about this as a molecule that leads to an increase, a positive, a PAM. I don't know if anyone watches The Office, but isn't that The Office? Yeah, The Office. A PAM is something that increases signaling, and a NAM is something that decreases signaling. Okay, now absorption. This is an important thing for you to know and understand. The human body naturally eliminates xenobiotics. Xenobiotics are chemicals that do not naturally occur or exist in the body. And it does that to prevent damage to itself. So it's almost like the body says, oh, well, I don't know what that is. So, and I've never seen it before, so I better get rid of it. Um, it's almost like the body's has no clue that something could be toxic, so it's just going to try to get rid of it. Obviously, there's sometimes that's a more effective thing than not, but there we go. Thus, the body uses the liver, super important organ, the liver and the kidneys, as well as other excretory glands to remove any xenobiotic or foreign substances from the body. So your liver and your kidneys, they're going to filter everything. They're going to filter your urine. You're going to filter your waste. All the water that's coming from your body is going to kind of run through there. And your liver and kidneys are going to detoxify it. So think about this as, well, livers and kidneys, or your liver and your kidneys, remove xenobiotic or foreign substances. Now, because of this naturally occurring, we have to find a way that allows for the human body to absorb a drug. Because we don't, if we find a particular drug that's very effective, we want the body to not say like, oh, I've never seen that before, I better get rid of it. Instead, we kind of have to like trick the body. We got to decoy the body into thinking that it's good. So typically, mimicking naturally occurring substances with good absorption and designing the drug to where it can be absorbed by the body is the first step in drug development. So mimicking naturally occurring substances. So it's almost like it's like you get this drug compound and you put like a little mustache and glasses on it so that your body's like, oh, I've seen that before. That's my old friend. Now, in order to administer a drug, there's a couple of different ways. You have your oral administration, just pop a pill or something like that. You have your IV or your intravenous method, so oral, intravenous. You have subcutaneous, so that would be that would be into the or below the surface, below the epidermis. Your intramuscular, which is into the muscle, transdermal, which is basically like this is depicting it really well, where it's like effectively the drug is on a patch and that patch sort of seeps in. This is effectively how, um, what are they called? Nicotine patches work. I think nicotine patches aren't really as popular as they were 30 years ago, but there we go. And then, of course, inhalation. So something, here we have a nebulizer or an inhaler, an asthma inhaler, for example. Well, when you use an asthma inhaler, you're taking on a drug. You're inhaling that drug. So it's going through your mouth, but it's aerosolized. It's a liquid. Or sorry, it's mostly a gas. Some of it might have liquid droplets, but it's effectively a gas. Now, oral administration, whenever you swallow a pill, where's it going to go? It's going to go into your gut. It's going to go into your small and your large intestines after it goes through your stomach. And so at some point, it's going to go through the liver, and then potentially it's going to go into your feces. If, however, you use transdermal, intramuscular, subcutaneous, or intravenous, well, then it's going to go through your urine or through your blood plasma to your kidneys, to your urine potentially. And it's also potentially going to go to your sweat glands and be excreted that way. Now, the nebulized or aerosolized compound is going to your lungs. Now, notice between all of these different systems, we've got these arrows going both ways. So what that's meaning is that you can inhale a drug, it goes into your lungs, it's going to then make its way into your bloodstream, and it's going to make its way into your blood plasma. And whenever it goes to your blood plasma, then it could go to your gut, it could go to your kidneys, it could go to your sweat glands. There's this interchange between all these systems within the body displayed here, and the reason is because there are. Now, when we think about these different methods of administration for a drug, you have a handful of different options. So if we think about an intravenous drug being administered, oh, that's not what I meant. A drug being administered intravenously, it's directly injected into the veins. You bypass absorption, goes directly to the bloodstream. It's going to have the kind of most immediate effect, and this is good for large volumes. If it's subcutaneously administered, well, it's injected into the cutest layer of the skin. It's going to slowly be absorbed, and the reason for that is there's not a huge amount of blood vessels. Your intramuscular drug administration, well, this is going to be injected, or the injection of the drug goes into the muscle. It's going to quickly go to the bloodstream and avoid that first pass absorption. So you're not going to have to worry about the endothelial cells in your stomach taking it on. Oral ingestion, well, it's ingested through your mouth. How well it absorbs depends on how well it avoids the first pass effect. So if it basically doesn't get into your endothelial cells in your stomach, it's going to go straight to your waist. Um, Reasons for these drugs, all variable. Intravenous, well, it might be something that it might want to be delivered over time. Um, so the special utility for IV drugs is it's done during emergency situations. Large molecules like antibodies require IV administration. What that means is that if you just inhaled one or if you just swallowed one, it's not, or it's too large of a molecule that's going to basically be processed out. Subcutaneous is good for slow release drugs, and it's good for, I apologize, poorly soluble drugs. So that poorly soluble means it just doesn't dissolve well. And I always think about whey protein and whether or not that goes into solution. Intramuscular is suitable for moderate volumes and drugs that are possible irritants. It's also good for self-administration. Your oral ingestion, it's the most common delivery for a drug. It's fairly safe because you don't worry about, cutting yourself or breaking a needle off or anything like that. It's most convenient and it's very economical. Now, we're going to look at the limitations and precautions. For IV drugs, you have an increased risk of some adversity. You must inject very slowly. That's why, if you're ever in a hospital and they give an IV bag or put a drug into an IV bag, I'm going to jump back here. This IV bag, that's like a liter. And that's going to take, maybe they'll do it for 45 minutes or something like that. So it gets delivered to your body over the course of 45 minutes. Um, and so that's where you're injecting it very slowly. It's not suitable for oily solutions or poorly soluble drugs. Um, you've got to use things that are smaller and not oils. Um, Subcutaneous is not suitable for large volumes. It's going to cause pain or necrosis from irritating the substances or from some irritating substances. Intramuscular may alter the interpretation of diagnostic tests. Exercise can change the amount of drug absorbed by the muscle. So sometimes when you get an IV or, sorry, when you get a shot intramuscularly, you might be told, oh, well, you got to rest for 6 hours or something like that. So that basically that drug has the opportunity to circulate throughout your body at the ideal pace as opposed to going very quickly. Oral ingestion. Well, drug can potentially be excreted easily without proper absorption. If your stomach doesn't pick it up, then it's going effectively to the toilet. This requires patient compliance. I've got kids, and if I ask them to swallow a pill or something like that, the Tylenol, they're not up for that. They're not ready for that. They can do like chew uh children's aspirin, a chewable one or something like that. But also one of my kids doesn't like to take any sort of medicine. So he's resistant to that, even if it is, oh well, it's not gonna hurt. He doesn't care. He doesn't want to take it. Intravenous, some examples. Well, an IV drug would be an antibody treatment. Most of your cancer therapies are IV drugs. Insulin is administered subcutaneously, and um, then intramuscular would be something like a vaccine or an EpiPen, which if anyone has a very strong allergy to, like, I don't know, something that's readily available, they probably have an EpiPen on them. And if you think about an EpiPen, well, it is good for self-administration. If you know someone or love someone who has an EpiPen, make sure that you know how to use it so that you can potentially help them out if they ever are in an unfortunate situation where they need you to. Last but not least, oral ingestible drugs, ibuprofen, most of your over-the-counter drugs are orally administered. Okay, so that gives us our talk about basically administration of drugs and absorption. Now we've got to go on to bioavailability. Okay, bioavailability is a very important concept and very important for any sort of drug. This concept is absolutely crucial, and bioavailability discusses the amount of the drug that's going to actually get to the site of action. Um, and the site of action is the location of the target protein. The first pass effect is as soon as the drug is taken, the drug is thrown away by the body because it is easily metabolized by the liver and excreted by the kidneys. When designing a drug, we want to have a molecule that can bypass or be minimally affected by the first pass effect. So we need something that's not going to immediately be thrown out by the liver. Now, organs that receive the most drugs first are going to be the liver, kidneys, and the brain. Now, delivery of the drug to the muscle, um, your fat and your skin are going to do it very slowly. One of the limiting factors is a drug reaching its site of action is the binding of drugs to proteins in the blood. So drugs in the bound form attached to a protein cannot travel through the tissue or across the tissue or a cell membrane to reach the target protein. Only drugs in the unbound form can travel into cells and to their target proteins. So, when it comes to distribution of a drug, what we've got to know about are these kind of different um, places within the body that the drug can go. So, next up is metabolism. Well, we have to know about how our body like chews up or utilizes a particular drug. Lipophilic or fat-loving nonpolar molecules are more difficult to remove from the body. Now, typically that's because lipophilic molecules are reabsorbed into the body by the kidneys. In order for the drug to be excreted from the body, it needs to be converted or metabolized to a more polar molecule. Polar molecules are easily excreted by the kidneys and thus result in faster elimination from the body. So the metabolism of drugs typically occurs in the liver and promotes their removal from the body. However, sometimes the liver can metabolize drugs into molecules that have biological activity or toxic effects on the body. So sometimes kind of the liver can make a mistake. Now, excretion. What's happening here? The kidney is the most important organ for excretion or for the removal of drugs and their metabolites. There are other organs that participate in this. We already saw basically the skin being an organ, your sweat glands, your salivary glands in your mouth, the lungs, the intestines, lacrimal puncta, your tear ducts. Um, so these are all important variables. Now, this is ultimately why breastfeeding women should not consume any sort of drug, caffeine, alcohol, or any medications, because the drug will be consumed by the infant through the breast milk. Using formula instead of breast milk may be a better option for mothers that require some sort of medication. Now, please note, um, that is absolutely something to speak with your physician about, um, because yeah, that's that. Now, there's for any and every drug, there's what's known as a therapeutic window and a therapeutic effect. So the therapeutic window is basically the window of time in which the drug is going to be functioning. And the therapeutic index is basically a measure of, if we look at this graph over here on the right-hand side, what this shows is kind of our therapeutic window. And this would be like our time. So what this shows on our y-axis is percent of patients responding. This goes all the way up to 100. And on our x-axis, we have concentration of our drug in the plasma. So our concentration ranges from 6 to about 18. That would be our therapeutic window, the concentration where we get a positive effect. Now, from this, we can look at the therapeutic index, which is going to show basically the toxicity of a drug at some point. So the therapeutic index is going to show the difference between, here's our, okay, sorry, the concentration of our drug over our 100% effectiveness level. So when we add more of that drug, or when we give more of that drug, what ends up happening is the concentration of the drug continues to rise. And at some point, it's going to be toxic or cytotoxic. It's going to kill cells. The concentration is going to be way too high. And the therapeutic index is simply noting the difference between concentrations that are healthy and effective versus a concentration that's way too high. So that's what our therapeutic index is. Now, our therapeutic window is the it's kind of looking at the effectiveness of the drug as well as the time where the drug started to be effective until it ultimately kind of stopped its job. So this 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 content had a lot of material. Now, what I want you to think about when it comes to this material is I want you to look at this slide and know these different variables, know these steps, these important things after finding a drug. I want you to know what absorption is. I want you to know about what bioavailability is. And then when we talk about distribution, effectively what we're talking about is, well, where's the drug going to go? Um, that's what is important for distribution. Um, and now on the right-hand side of this, we're looking at the distribution of different drugs on parts of one protein. So when we talk about distribution, what we're most interested in is kind of throughout the body, um, and where that drug ultimately is. I think that if there's like the most important thing, looking at this slide right here, I think that the basically those first two things, absorption and bioavailability, are things that I would definitely have good definitions on. Um, So that's what I wanted to cover for this. We will get into talking about drugs and their design a little bit later, but these are kind of all of the important things that you need to know about how drugs are processed. Um, and so with that, I'm going to stop my share. I'm also going to say that I hope you have a great day, and I will screen share stop. Okay, good. That's right. And that's what I got. I hope you have a good one. Thank you. Bye.